GRMnet, I will be talking about the role of hospital administrators in respect to the new digital age. So what that means is, we as administrators, okay, first the table of contents, we'll talk about the hospital administrators and their expectations in the new digital age, the holistic approach to patient care, and what the factors that impact patient care, and of course the MSTAR Health e-governance platform. Briefly, we'll talk about that. So as hospital administrators, we understand what are our expectations, roles that are there in a hospital. Now in the new digital age, with a lot of technical development, technology tools coming in, all of our expectations are in one way or the other being met by some tools or some applications. So for example, one of the activities is direct, supervise, evaluate work of medical and nursing and technical staff. So we have applications ranging from ERPs, workflows, and profiling tools, where we can define what kind of hierarchy in an organization it is, what are different roles of individuals in that hierarchy, what are the proving authority, and then we can actually do our dedicated supervision and evaluation work accordingly. Similarly, we have something called plan, implement, administer programs and services in a healthcare or a medical facility. For that, we have softwares like project management softwares, where we can actually go in depth and define the work breakdown structure. We can define the responsibilities, the roles, the time that should be taken, and we can actually administer and monitor those activities through these softwares or through these tools. Similarly, we also like to monitor as administrators the use of diagnostic services, patient beds, facilities, and the staff, if it's being effectively used or not. So we have a lot of tools and reports, wherein the reports give us automatically the bed occupancy ratio, the work allocation, and things like that. Likewise, some of other responsibilities include preparing activity reports to inform the management of the status of implementation of plans, programs, services, other operations. So now these days, in the new digital technology era, we have AI and machine learning based, analytical based reports, which give us information like what is the turnaround time of diagnostic reports, what is the turnaround time of the consultant while seeing the patient, what is the waiting time of the patient. So those information is already available. Also, for example, one of the responsibilities of the healthcare workers is to maintain awareness in advances of medicine, computerized diagnostic and treatment equipment, data processing technology. So there again, we have tools available for online self-learning and training platform. So these are some of the activities which as hospital administrators we do, and technology supports us. Now, having considered that, patient care is just not medical care. It is a holistic three-dimensional approach is not what we believe. So what that means is, so the three dimensions, the physical dimension, the psychological, and the social, that make an individual or a human being, all these factors are responsible for good and better patient care. Going into a bit of detail, physical factors as hospital administrators include the hospital space and the infrastructure, the area that is being covered. So that needs to be proper. The resources, the facilities, the equipment, they need to be latest, they need to be in proper shape. Patient security and patient physical privacy, that is at most important in patient care. So that is something also we need to take care as administrators. Then the ambience, physical factors like there should not be too much of noise, there should not be too much of crowding in the OPD areas or the waiting areas, and there should not be any disorderliness to say. So these are some of the physical factors. Then we have some psychological factors. Now these psychological factors are like how a patient is received in a hospital when he walks in, or psychological ambience factors like the smell, the odor should be proper, the hygiene should be there, sanitation should be there. So all these needs to be in place. Then the services should be financially accessible, affordable by the patients. There has to be an effective feedback and grievance redressal mechanism. So, and then of course patient satisfaction. These are some of the psychological factors. Coming to social factors, of course, if there is word of mouth appreciation about the hospital or not, If the hospital has a community outreach and it has reached out to the local neighborhood areas, if the patient trusts the doctors, the staff workers in the hospital, and of course, how accessible is the doctor post consulting or post-treatment, how accessible he is, how readily he's available to further diagnose or help. And then, of course, the presence of hospitals in social media, the popularity. So these are some of the social factors which impact the patient care. Now, these factors are there, all right. Now, to effectively manage all these three physical, psychological factors, there is MSTAR Healthcare e-governance platform, which we believe is an answer to all these impact factors. What this platform is, so this platform consists of various components. They are the telemedicine or the telehealth platform, the hospital expert system, the college expert system, electronic medical record management, the visitor management, and of course the continuing medical and professional development management. All these, the data which gets generated gets converged in a healthcare portal, and of course there are AI and ML based analytics that is available that can provide ready information for decision making. So as part of this platform, specifically for hospital administrators, what are the specific tools that are available? These digital tools are the MSTAR training support platform and the MIP collaborative tool. So these are modern tools that the administrators can access. Training support platform, of course, is a platform to develop, deploy organization policies and processes. They can establish objectives, maintain communication between different departments, governing bodies, statutory stakeholders, can plan, schedule, coordinate activities of the department, of the various workers, can generate a lot of reports of training support platform based on how much training a person has got or how much training he's lacking. So that information can be available. New joinees who are joining in, you can conduct induction or in-service training. We can consult other external businesses, stakeholders, experts, and other community members. We can create content, SOPs, guidelines, processes to manage operations in a hospital. There's an intuitive interface to develop this instruction material. And we can also plan and promote health drives in a community. Then there are whatever medical advances are happening or the latest trends in Medicare that can be made available online, that can the peers can collaborate and access that information. And of course, the customer service orientation is the most important feature. Likewise, then we have MIP. MIP stands for Master Implementation Practices. It's a collaboration tool which helps you in implementing any kind of programs or medical policies or government schemes which are there to implement those, to monitor their effective utilization for the beneficiaries. It's a collaborative tool. We can create service requests pertaining to equipments, facilities. We can interact with various departments. Of course, any service resolution, triage, that is also part of the system or internal workflow for a resolution is there. We can communicate with staffs, doctors, management members through this system. The entire facility infrastructure maintenance, annual maintenance contracts, comprehensive maintenance contracts, these can be managed. Alerts can be given at timely for renewal of insurance policies, AMCs. And then, of course, we can conduct inspections in compliance with various guidelines like NABH or National Health Authority. Various inspections can be done. So all in all, this is a collaborative tool. So this is what the administrators of today in the new digital era can utilize and use these for their effective operations and better management of their work. That's all. Thank you. So, and if there are any other questions or details, we are available outside on our stall. Please feel free to reach out. Thank you. Thank you very much.
Thank you, sir. Moving ahead with the sixth session, which is based on the theme, Hospital Infection Control, How COVID-19 Changed Healthcare. I would like to invite our first distinguished chairperson on the dais, Professor Dr. Madhavanandakar. Sir is Executive Director, AIIMS, Darbhanga. Sir is Professor and former Head, Department of Surgical Oncology at All India Institute of Medical Sciences, Bhubaneswar. Requesting our second chairperson to come up on the dais, Professor Dr. Farooq Chand. Sir is the Medical Superintendent, Sher-e Kashmir Institute of Medical Sciences. Sir is the member of Hemovigilance Program of India. Sir is the member of Advisory Council of Diplomat of National Board for Hospital Administration. Further inviting our first esteemed speaker on the dais, Dr. Arvind R. Dr. Arvind R, HOD, Infectious Diseases, GMC, Thiruvananthapuram. Sir is also a scientist at GMC, Thiruvananthapuram. Requesting our second speaker to come up on the dais, Dr. Jawahar S.K. Pillai. Sir is a professor and head, Department of Hospital Administration and Joint Medical Superintendent, All India Institute of Medical Sciences, Bhubaneswar. Sir is also Principal Assessor, NABH. Would invite a third speaker on the dais, Dr. Kavita Raja. Ma'am is a Senior Professor and Head, Department of Microbiology, Sri Chitra Tirunal Institute for Medical Sciences and Technology, INI, under the Department of Science and Technology, Government of India, Trivandrum, Kerala. Ma'am is the Founder Secretary of the Academy of Clinical Microbiologists. Our next speaker will join us virtually, Mr. Jennings Joseph, MM. Sir is an alumnus of Deakin University, Melbourne. Sir is a registered nurse, Gayndah Hospital, former registered nurse, Northwest Hospital and Health Services, also a former staff nurse, Government Medical College, Thiruvananthapuram.
Before COVID struck us,
I'm requesting a chairperson to commence the session.
we had thought that the era of infectious diseases has gone. But COVID had something else. Administrators were caught unaware with shortage of PPEs, oxygen facilities lacking. Clinicians feared to go into the areas. Private practitioners didn't go to their private hospitals, which meant revenue losses. Microbiologists were asked to do these many tests per day, and nurses had a tough time going into the wards, into the infectious disease wards. During next half an hour, we'll be deliberating and discussing on the various challenges our clinicians, administrators, microbiologists, and paramedical staff, especially nurses, face. So I welcome Dr. Arvind R, HOD, Department of Infectious Diseases, Government Medical College, Trivandrum, for his thoughts. Thank you, sir.
Good evening, respected chairpersons. I would like to thank the organizers, especially Jawahar sir, for this opportunity. We bring greetings from Kerala because all the speakers in this session are by birth from Kerala, including our beloved Jawahar sir. So the topic allotted to us is actually hospital infection control, how COVID-19 changed healthcare and the clinician's perspective. It's actually not moving. Slide changer is not working. Heard Dr. Lallu madam discussing about the need to imbibe the culture of safety in our hospitals with regard to the patient care. What is common to these two persons is, on the right you can see Dr. Carlos Urbani. In 2003 he died following SARS. Because SARS was detected first in Vietnam in 2003, and he was the doctor who alerted WHO. He was working for Medicines Sans Frontier, and he was the doctor who alerted WHO of the occurrence of probably a new emerging flu in East Asia. And he succumbed to the disease. And this is our own sister Lini. who succumbed to Nipah virus in 2018. So the infection control is not only about protecting the health of the patients, but it's also important as far as the healthcare workers are concerned, because as a chairperson did say, one of the major problems that many of the health systems face with regard to the COVID-19 was the insecurity among the minds of the healthcare workers. They were afraid to go to this, the COVID care areas, etc. So and that had to be allayed, and that was a major challenge that majority of the countries as well as the states did face. But Kerala had one advantage. So if you go through literature, you can see that majority of the East Asian countries fared pretty well when they tackled COVID-19. It was said that it was due to their prior exposure in dealing with the SARS epidemic in 2003. Kerala had some sort of a rude jolt to reality when the Nipah struck us in 2018. You can see two clusters there. That is, we lost around 20 people to Nipah virus infection in 2018. And you can see two clusters. So one cluster occurred in our CT suite and one cluster occurred in ICU. That is, from two patients you can see that the other patients got infected and they succumbed to the disease. Actually highlighting the importance of the fact that emerging infections like say SARS or Nipah or COVID-19 can occur at any hospital at any point of time, thereby exposing not only the patients who are admitted in the hospital or the bystanders who are standing in the veranda or to the healthcare workers. And that clearly indicates the importance of having a very vigilant infection control and prevention and control system in all hospitals at all points of time. So these are the lessons that we learned from Nipah. That is a need for health system preparedness. It's not about pre-COVID or post-COVID like that. All the health systems should be in a perpetual state of preparedness, because the next patient you are seeing in the hospital, some person coughing in the ward due to influenza, could be avian influenza or something like that. So we should not expose ourselves or to the patients to emerging infections. So all the health systems should be prepared at all points of time. The second was actually the focus on infection prevention and control. The frequent training, there is a small group learning session should be conducted in different parts of the hospital at all points of time. For example, the donning and doffing, etc. So I think that majority of the states got used to this donning and doffing following this COVID. Kerala had its experience with Nipah, so almost all the healthcare workers were aware of this donning and doffing procedures, and so it was nothing new to us when COVID struck us. And then the importance of effective triaging for respiratory infections and the importance of having cough corners in all hospitals. Because Nipah starts with a respiratory infection. It's very difficult to differentiate Nipah from your common flu or say dengue infection for the first 5 days. It is on day 5 that the patient develops seizures or altered sensorium. The thing is that any patient who is coming with any respiratory symptom to your hospital should be isolated at the casualty level itself. Then we need to have an algorithmic approach to diagnose emerging infections. For that, following Nipah virus infection, a high-level committee was set up by the government of Kerala, and the question asked was, so can we prevent this, the mortality due to these emerging infections in future? We said it's impossible, because I come from a government medical college where the exact number of beds are more than 3,000, and the number of patients at any given point of time will be twice the available number of beds, and the casualty is always crowded. So we don't know which patient is going to be an index case or an emerging infection. We don't know that. So that is actually the importance of having a very good infection prevention and control system, where you need to consider each and every patient as infectious. Then the need for dedicated isolation facilities. The problem with having a hybrid hospital means that the Nipah in 2018 occurred in Calicut Medical College. The entire medical college, one area was converted to a dedicated isolation facility. So what happened was that because the patients were so afraid, so other people were so afraid that they did not come to Calicut Medical College for seeking other benefits like say surgery, etc. They did not come to the hospital. So the entire hospital, which used to cater to say more than 10,000 patients per day for around say 1.5 months, were catering only to patients with Nipah virus infection, and that did happen during the COVID time also. So what we learned is that ideally we should be having dedicated isolation facilities for catering to patients with emerging infections. when you are allocating a portion of your hospital for taking care of emerging infection, one thing is you might scare away the other patients. Other aspect is that there is always a chance of other patients getting infections from the patients with emerging infections. Then the need to ensure seamless flow of required logistics during 2018 Nipah. So probably initially there was a shortage of PP kit, etc. At that time we learned that if you want to keep the morale of our healthcare workers very high, we need to have a seamless flow of APP, disinfectants and all those things. And that is the reason why probably during the COVID of the last 2.5 years in Kerala, we never faced any shortage of anything like oxygen shortage, etc. were not reported from Kerala. Then the healthcare worker psychosocial support. This is actually very, very important component. In our hospital also, there were problems with the sisters breaking down due to stress and all those things. So what we did ensure was that all our healthcare workers, when they got infected, including their, the family members, etc., there was an assurance that the hospital will take care of their health needs. For that, they should have belief in our infection prevention as well as our care delivery system. So those sort of things are also very important. Then the staff rotation policy, the staff burnout policy, all these things are very important. The point of care testing with minimum turnaround time, that is also very important as far as isolation is concerned. So all these things actually we learned because we were born during the 2018 Nipah outbreak which occurred in Kerala. Because of which in 2019 also we had a case of Nipah report from Kochi, and we could able to contain the infection, so it did not spread to anyone else. 2021 also we had one case, but we were able to prevent infection spreading to others. Because of the experience with Nipah, the COVID-19 did not pose that much of a challenge as it did to other places in India. So this is why all healthcare systems should be prepared. This is the WHO blueprint, prioritizing disease for research and development. These are diseases where the vaccine is not available or an effective treatment is not available. So this is actually the list for 2022. From 2018 onwards, they are including one disease known as disease X. Disease X means that as of now, we don't know what this disease X is. It could be a pathogen in animals which could cross over to humans at any point of time and can trigger out of an epidemic. For example, in 2019, November and December onwards, there was a clustering of cases of influenza in Wuhan. At that time, we never knew the etiology was SARS-CoV-2. So at that time, it was labeled as disease X. In 2020, January 6, the genome was shared. At that time, we identified it as belonging to, say, the SARS-CoV-2, etc. Then the term will be changed from disease X to the newly diagnosed pathology. So all the health systems should be on the lookout for, say, disease X. The patients you could be treating, say, clustering of cases of influenza occurring could be a new pathogen. So it is defined as a mystery illness which could kill millions. How can we actually take care of us and our patients? It is through investing in very good infection control practices. And then, so our outbreak response. The outbreak response could be reactive or preemptive. Usually what we do, that is, after burning our fingers, if you are mounting a response, that is like, say, firefighting. That is referred to as the reactive response, like what Kerala did in 2018 Nipah. That is, the first case, we missed the first case. From the first case, a lot of people got infected. We were able to diagnose Nipah only from the second case. That is why we lost around, say, 20 people to Nipah in 2018. Whereas in 2019 and 2021, we were able to diagnose Nipah with the first case itself. So we were able to prevent the spread. So the reactive response is about firefighting. Instead, we should be focusing on preemptive response. Preemptive response means, it depends on epidemic forecasting and all those things. This is about the outbreak alert and response system. So if you're able to diagnose the first case, if you are not diagnosing the first case, and if there is a delay in diagnosing the index case, the opportunity for control is actually is very less. Whereas, if you are able to diagnose the first case early, you can mount an effective rapid response. The opportunity for control is actually very, very good. So this is something which is applicable in the hospitals also, because infection control practices can be adopted, that's a transmission-based precautions can be adopted only if we are able to identify which infection the patients are having. And this is actually following the 2018 Nipah outbreak, the algorithm which the government of Kerala came out with. So outbreak monitoring units were set up in all the government institutions, the tertiary care centers, with the aim of picking up these emerging infections at the earliest so that we can prevent the collateral damage. So usually majority of the emerging infections present as say a pneumonia, ARDS, hemorrhagic rash, meningoencephalitis, gastroenteritis, or as acute liver failure. So after ruling out all the common infections, we decide whether it could be an index case of an emerging infection, and when we will take the patient for some multiplex PCR. For example, COVID-19 also was diagnosed using this algorithm. If you remember correctly, the first case of COVID-19 was identified in India, in Kerala in January 30, 2020. The first case of monkeypox also was diagnosed in Kerala, because we are on the lookout for diagnosing emerging infection using this algorithm. This is one example how we are putting this algorithm in practice. This is a 34-year-old lady, housemaid in Qatar. She developed the influenza-like illness and they flew back to Kerala. And these are the differentials entertained. She was having a viral prodrome and pneumonia. So these are the usual DDs. But since the patient is hailing from Middle East, we need to rule out the sixth differential also. It is a Middle East respiratory syndrome. Also has to be ruled out. So this is how the OME workflow works. So there is a clinical alert. The clinical alert came from the ward saying that this lady had flown from Sahatar and she is having features of influenza. So it could be MERS. We need to isolate the patient. So immediately a clinical alert was given. The outbreak monitoring unit meeting was held. The patient was isolated. The adequate infection prevention and control measures were initiated, and the sample was sent for multiplex PCR, and it actually turned out to be H1N1. Okay, and then the alert was withdrawn. It could also have been MERS-CoV as well. This is actually what we learned from Nipah. So prevention is better than care, especially when something has no cure. So there is no point in diagnosing, say, the MERS infection in that patient after, say, 2 weeks. By that time, everyone in the hospital would have been exposed to MERS, especially when we are working in government hospitals. The number of students as well as the other patients interacting with that particular patient is going to be very high. So that is the importance of infection prevention and control in the beginning, even without knowing the diagnosis. So now coming to COVID-19. So why I mentioned this much about this Nipah and the state's alertness is because of this, the alert system. Okay. Because of this alert system, we just extrapolated our learnings to COVID-19. It was not very difficult for us to tackle that. So the baseline capacity, the burden of disease, the COVID-19 transmission dynamics, all of these things we learn from. So our practice is about adopting the best practices from the successful models, like say the Singapore, etc. The problem is that the COVID-19 suspects, they won't come walking in saying that we are having COVID-19. They could come to our usual OPDs, can come to the casualty as well. So all these areas will have to be covered. So the focus on not only the patient's bystander could also be having the same infection. Also, and the healthcare workers. So all these things we did adopt. And then the problem is that we cannot create negative pressure rooms everywhere. So we need to identify areas where there is high inoculum load of virus, like where these aerosol generating procedures are going on, and there probably we can introduce this the exhaust or these negative pressure rooms, etc. And then since all governments are resource limited settings, our focus on infection control was on the ICUs. But then what COVID-19 taught us is that we can have clustering of cases from the wards as well. So after this, we started taking infection control seriously in our wards also. We started this the checklist-based infection control so that we can adopt the gray areas in the wards as well. And then, so this is the most important thing, something which is different from Nipah, because Nipah, the spread is not, say, droplet or airborne spread. Airborne spread for Nipah is not there, but for COVID-19, airborne spread is there. So as far as IPC is concerned, the COVID is more challenging than Nipah. Negative test results do not rule out infection. That is very, very important. consider each and every patient, bystander, and co-workers as infectious. Your health is in your hands. That is something that actually the emerging infections are teaching us again and again. And I will end with this slide. If you don't like what you are reaping, you had better change what you have been sowing. So that is very, very important, because in 2017, as part of our Kerala Antimicrobial Resistance Strategic Action Plan, we handpicked nurses from all the government medical colleges, and they were given 7 days training in infection control. And they were deputed as infection control nurses across the state. And they were well versed in donning and doffing. 6 months later, Nipah struck us. The doctors had no idea about donning and doffing, but the sisters were well trained in the donning and doffing practices, and they became the brand ambassadors for all these IPC activities in Calicut, so that we could avert a big scare. The sister that we lost to Nipah was not working in a medical college setting. She was working in a taluk hospital, who attended to the patient first, and she succumbed to the disease. And I believe that the onus on tackling emerging infections is on investing in infection prevention and control, because we don't know what next patient that we are going to see is going to have. It could be an encephalitis or an ARDS due to an emerging infection. So thing is that we need to focus on standard precautions. We need to see each and every patient as infectious and invest in infection control and improving the quality of healthcare. Thank you very much for this opportunity.
Okay, good evening. We'll take the questions at end. Yeah, good evening. I just before that showing my outset, I show my gratitude to Professor Dr. Jawahar, just calling me and involving me here. That I am really grateful. Next speaker is our very own Dr. Jawahar. Before he will speak, I'll tell something about him. We both were working in OT committee here in AIIMS as a surgeon. I was very skeptical about these infections, all these rates, we were discussing regularly. And he was simultaneously in charge of our infection committee in AIIMS. That's why it is very pertinent to listen from him after coming, that's like COVID outbreak. He was the front run to make the strategy and coordinating everyone, how we'll handle this COVID infection, and simultaneously taking care of like what for surgeons, like surgical site infections, cross-contamination, what Dr. Earlier they told, all this. Let's listen to Dr. Jawahar.
Thank you, Dr. Kar. He has been with us as the faculty, HOD of Surgical Oncology, and presently Director of Darbhanga. Thank you for joining us today. And Dr. Farooq Jan is again my old friend. We have been interacting for around 2 decades. So I have met him today, maybe after a long period of a decade. So thank you, Dr. Jan, also for joining us. And Dr. Arvind and Dr. Kavita and me, we were together in the infection control team of Sri Chitra Tirunal Institute of Medical Science Technology, where I worked for about 20 years before joining AIIMS Bhubaneswar. So Arvind, he's a giant in infectious diseases specialty, and he single-handedly deal with the COVID as a COVID nodal officer for the state government of Kerala. And he has been exposed to all the struggle that the state went through in the COVID pandemic. So I thought it was appropriate for Dr. Arvind to be speaking to you regarding this clinician's perspective on the COVID. And also Dr. Kavita Raja, who will be following me. She is the HOD of Microbiology at Sri Chitra Tirunal Institute of Medical Science and Technology. And I remember her spirit and passion by, going after the surgeons regarding antibiotic policy, regarding surgical site preparation, preoperative preparation. So to stabilize the system, she had taken a lot of struggle. So she will also be able to talk from her heart what she has been doing. So regarding this, administrator's perspective, I know many of you are administrators, and what I am going to speak is what you know. There is nothing different. But then I had a rare opportunity. The COVID first case, which was detected here, was the son of the medical superintendent of AIIMS Bhubaneswar. So he went on a quarantine immediately because that was a second case in Odisha. So I took charge as a medical superintendent, and then for 1 month I was in charge of the whole hospital. So the initial 2 weeks I stayed in the hospital in the private ward because that time people were totally confused. Morale of the staff was lost. We didn't have the protocols. The information regarding the disease was not available. So it was totally in a chaos. Then another 2 weeks, I stayed in my guest house, which is in the same campus. At the same time, we were really, everyone had a skeptical about the infection, which the family members could also develop because you are exposed to the disease and then you will give it to them. So it was a really tough time, and then we had really learned a lot during this, so I thought I will share some of my thoughts. So before that, I thought I'll share, because today, the whole day, we have been listening to various talks, and just to take a lighter note, so this is the hospital overview. It's a 960-bedded hospital, and there are 15 ICUs and 32 wards, 25 modular OTs, and average daily OPD is about 4,000, and average admission per day is about 100, and major surgeries per month is 850. And we are catering to various neighboring states in addition to Odisha. So, the start of the pandemic, we saw everything stopped. We couldn't move, no materials, nothing. So totally life was standstill. Then we started the isolation, quarantine, and then we went to the new normal. And the proposal was to sit at home. But the healthcare workers was the only group which could not sit at home and had to travel. So initially there were some studies which said that there was a dip in infection risk for health staff on HCQ. So in HCQ there was a big scare, and even the president of USA declared that they were taking up tons of chloroquine HCQ from India. Later on, we saw that the COVID paradox, where the healthcare staff, they were shunted out from hospitals because there were no patients, there was no revenue, so the staff came down. And later we saw the era of webinars. So every day we will have some 3-4 webinars, and over a month we will accumulate a lot of certificates. And this was the dress that was there, and there were so many stories regarding the children going to schools. The educational institutions were stopped, but later restarted. And then, the issues with the work at home. Then there were, issues whether mask is important, which kind of mask is important, whether N95 or cloth mask. So that confusion was also there for a long period. And then the lockdown led to the mental health issues, and people died in the hospitals or in the US after drinking sanitizer. That was another theme which was brought out. And someone is asking, what did you do in a year? So whole year he was washing hands. And we were finding it difficult to justify our intentions to the people. And then, as you see that this is a newspaper report, as COVID cases dip, the queue grows at AIIMS. This is a Bhubaneswar report. And the government come out with a guideline, 50 to 80% of the bed should be reserved for the COVID. These are our stories. And regarding this community spread, again, what level we are spread, and so that was another theme which was there. Then, if you look at the doctors, they were very careful, they were overprotected. At the very same time, others were not bothered. And then the government had to come out with instructions that suppose the doctors are had to be quarantined and they have to be given special leave. So we had the structure of a COVID-19 team here and a COVID-19 advisory group. So we were working with two bodies here with representatives from administration, clinical departments, and almost daily there was a review. And most of the reviews, the director used to be leading the team. And the immediate challenges used to be that whether we exist, when are we going to die? And because of the situation, the leadership had to be very strong. And the high transmission rates, and we had to stop the OPDs. So there was a cry and hue regarding the patients who are coming to the OPD, how to manage. And there were increased loads in the trauma emergency. And they were again frantic out of there, how many of them are going to be infected or not infected. And there are so many doctors, nurses, healthcare workers getting COVID, and there was shortage who will work. And there were hardly any SOPs. So from no valid information, later we became information overload. Webinars, and that was the situation. So we created the facilities here, as you can see, that isolation facility. We created separate block for wards. We created separate screening OPDs, sample collection centers. These were all done during the initial couple of weeks. We had to modify various areas, and I remember the help that was extended to me by the earlier speaker, Dr. Renju, who was also the nursing superintendent, and all my colleagues in the department, including the residents. So the screening OPD, trauma ward, isolation facility, donning doffing, ICU, special OT for COVID, RT-PCR testing center, the sample collection, radiology services, transporting the COVID patients to the CT scan was a challenge. The waste collection, initial days, nobody was ready to take the COVID waste, and our resident, Dr. Biswajeevan, who was anchoring this inaugural session, he had picked up the waste. So to that extent, we contributed to this particular issue. So this was the isolation facility that we had created with the screening area, registration, and the nursing station and the patients for ICUs and separately for the wards. With regard to information communication, we came out with a telemedicine numbers. So this was tailor-made with the WhatsApp calling, and people, till date, we have been able to give 1.5 lakh teleconsultations through this facility, along with the e-Sanjeevani and Swasthya app that we have developed. So we have developed separate helplines for COVID patients, for staff mental health, and daily reporting of statistics. So it was a major activity. SOPs and IECs, we have come out with a COVID-19 protocol with all the SOPs combining housekeeping and clinical pathways and infection control, all inclusive. The hospital operations, again, we had to have our processes in place for various things. And support services like pharmacy, the store, CSSD, linen laundry, waste management, transportation team, report dispatch, control room. We were operating 24 hours, the administrative control room and grievance management. And the treatment protocols were changed. Antimalarial drugs, we had a study here, ivermectin was found to be good for the COVID. So again, there was a controversy whether in the international scenario they didn't accept it. Remdesivir came in, then low molecular weight heparin, roll-up steroids, the availability of oxygen, and ultimately we had the vaccine. And then there were initial repercussions, whether vaccine is going to be effective, what are the complications. So these are all the story that we know. And the human resource, the morale of the employees were affected, the staff were affected with COVID. Then we had to provide isolation, quarantine facilities, special accommodation, leave, risk of infection to the family. And there was an incident where our housekeeping staff who are collecting the COVID waste, the villagers, they locked him up and they said that you cannot go. If you want to work in COVID unit, then you cannot stay in our village. So we had to deal with that crisis also. It became a major media issue. Then we had to deal with the training, the occupational injuries. We had organized a COVID appropriate behavior campaign for 50 days. And 50,000 of our staff participated. 50,000 of audience were there for this campaign. And indirectly, 2 lakh people have participated in this campaign, which ran for 50 days. And we rewarded and recognized the healthcare workers who were involved with this. Materials, I need not, because of the scarcity of time, I am skipping this. We know that the drugs, PPEs, etc. And then we had to come out with re-sterilization systems. Some new equipments have come up, etc., etc. Telemedicine, which I have already described. Infection control practices. So we had instituted the best ward ICUs, hand hygiene, and the infection control team, who are also part of this conference, they made their presence felt, and then it was a round-the-clock exercise for them. And staff training we have taken up in a big way, and every day we used to run some of the training programs. And the financial aspects, as we know that there were issues in budgeting, funding, consumables, a lot of remdesivir had to be bought, and different supplies. So suddenly the expenses went up. And we had to reduce the shift hours. So accordingly, the number of staff increased. Yeah. So I'm winding up in 5 minutes. The role of social media. So initially it was, we can look at it both ways, negative. There were fake news, social panic was there, information overload and ostracization. Positive, it led to the quick dissemination, quick help for the emergencies. IECs were there in handheld devices, early alarms, WhatsApp group worked very well during this period. And even the government started communicating through WhatsApp groups. And there were a lot of appreciation for the COVID warriors. So this is our statistics and the entire representation of the hospital activities ranging from support services to telemedicine, helpline, communication, human resources, the infrastructure that we have created, appropriate COVID-appropriate behavior campaign, infection control team, telemedicine, cleaning, sanitation, signage, IEC, BMW management, clinical protocols, and vaccination. So this is the first wave, and the second wave, as we can see, the number of cases, admissions were more with the second wave, and also the RT-PCR testing. So this is our data 2021. And finally, the changes that we have seen, the positive and the negative. E-health became prominent, e-orders were popular, hand hygiene became more important, SOPs were in place, and there was a lot of emphasis on communication, and we had instituted this video conferencing with the patient relatives who were admitted. Telemedicine became popular, e-Sanjeevani by the government of India, and this also contributed a great skill training, got a lift, and lot of technologies were developed by various agencies. Increased funding for health, government also put up a lot of money in the budget. Increased availability of equipments. We suddenly got a lot of ventilators, some on donation, some by government. Vaccine development, that is a major landmark achievement by India, which has helped to control this disease. And monitoring improved. And education, even today we had a lot of speakers virtually speaking. This is all due to the impact of the COVID. And there was a lot of emphasis on hospital administration, community medicine, family medicine, microbiology, infectious diseases, critical care, and respiratory medicine. These specialties became very prominent during this time. So there were teamwork, and there were a lot of papers throughout the country, throughout the world. A lot of publications came out, and health-seeking behavior, and mortality, morbidity was a negative side, and documentation improved. Data, statistics, daily reporting, and increased use of consumables, so which increased the cost of healthcare, and role of infection control improved, and a lot of surgeries were postponed and delayed, and waste management became a critical issue. So the take-home message, in a crisis, the leadership, the vision and strategy is very, very important when you have to take up the challenges. And scientific management skills and the professionals of hospital administration were recognized. And the preparedness and the PDCA, the basic mantra, became relevant. So thank you very much for patient listening.
Thank you very much, Dr. Jawahar, for a nice talk. Indeed, it was an uphill task for administrators who had to work 24/7. We in UT of J&K saw peculiar improvement in the healthcare delivery system, that was development of a proper referral system during COVID times. Because nobody would accept a patient without a proper referral, and whosoever would refer a patient would be asked that what was the indication of referring this patient. Now it's up to us to maintain that, and if we can see if it continues during the normal times. Thank you very much, sir. Now, microbiology of infection control, all of us know, and microbiologists had a lot to do during COVID times. In fact, the Department of Virology is improved, new technology was brought in, and in fact, when the COVID came, there were few laboratories which were able to do RT-PCR testing. The infrastructure was upgraded, the technology was upgraded, and we have Dr. Kavita Raja, HOD Department of Microbiology, who will be talking about the microbiologist perspective regarding the hospital infection control and how COVID has changed the things. Thank you.
Okay, I think I'm audible now. First of all, a big thanks to all those who are here for the last talk of the last session. I hope I'll rise up to your expectations. So as a microbiologist, of course, we have got a lot of prominence in the last few years. And when Dr. Jawahar asked me, I did not know how he knew that I would be able to give justice to this talk, because basically we are in a non-COVID hospital. The microbiologists in COVID hospitals would have a lot of stories to say, but what would a non-COVID hospital say? Maybe he was curious about that. That is why he gave me this assignment. So let us see what we did. How is it? This one. Okay, thank you. So I will divide my talk into 3 areas. First of all, the pandemic itself. Second, the healthcare associated infections. And third, the prevention and screening, that is the RT-PCR test. Let me tell you something about the setting. The Sri Chitra Tirunal Institute for Medical Sciences and Technology in Trivandrum. It's under the Department of Science and Technology. It's a super specialty hospital. And it's a non-COVID hospital which is inside the campus of the Government Medical College. So we are very close to a COVID hospital, but ours is a non-COVID hospital. The problem is that we are mainly the neuro and cardiac sciences hospital, super specialty for neuro and cardiac sciences. So when the medical college shut down for COVID, that is all the cases were COVID cases only, no beds for any other cases. The government, we asked whether we also should be admitting COVID cases. Then they said, no, there will be people coming with emergencies in heart and also in the neurosciences, aneurysm or CABG, needing CABG. So they said you continue with your work. So the work that we had was to maintain our hospital properly so that all those who need other services other than COVID services would not be disappointed. So what happened was we are still in the community, and the community was undergoing a pandemic. And all those coming into the hospital, the doctors, the nurses, the attenders, the patients, the bystanders, they were all coming from this community, and all of them could probably carry the virus into the hospital. Once it comes in, we would be no different from any other hospital, and the hospital would shut down. That will mean a break of our promise that we will take care of all the other patients, the heart patients, mainly the heart patients and the neuro cases. So that would be broken. So our prime responsibility was to keep the hospital open. And even one case reported in the hospital came into the media. Sri Chitra is shutting down, like that, as if it's a big thing that has happened. And so we had to be very careful. And I'll just discuss one cluster of infection that we got and how we managed to get over that. The clusters within a pandemic experienced from a non-COVID super specialty hospital. So of course, when COVID came in, like everyone said, we had some general measures. We developed a COVID infection control manual using the protocols given by WHO, CDC, Ministry of Health, Government of India, and Health Department of the State of Kerala. Then we gave training to all the staff for donning and doffing, proper use of masks, gloves, hand washing, ventilator care, and we also conducted online webinars. OPDs were changed to suit the COVID protocol, cuff corners, etc. More donning and doffing rooms were constructed in the existing areas. Few beds in each ICU and ward were designated for isolating COVID patients, because patient admitted for a surgery may suddenly turn out to be COVID positive, so that patient has to be isolated. And now, let us just compare what happened in the community and what happened in our hospital. It's not coming. Is it? It's not there. That pointer. This one, no? If you see that I have given the graph as a proportion of cases contributed by Sri Chitra Tirunal Institute in percentage compared to the community. So in the community, these are the number of cases in Kerala, and these are the number of cases in SCTIMST, and this is the percentage. So you can see that first case we had was a doctor who returned from Spain, and since there were only 239 cases in Kerala at that time, this came out to 0.42%. But after that, we did not have any cases, mainly because we did not admit anybody, and the hospital was almost closed down. There was nothing happening. That is why we did not have. Then slowly in July, we opened up for the surgeries, etc. And see, the 7 cases came up. But in this September and October, you can see the number increased and the percent, 0.13%. So why did it increase in September, October? Because we had some clusters of cases. And it was our responsibility to reduce this percentage and bring it down. So this is what you can see here also, but we were successful in bringing it down. How were we successful? We decided on a protocol on how to manage this. If a patient or staff develops symptoms or becomes RT-PCR positive, the patient, if it's a patient goes into COVID isolation area. If stable, the patient is shifted to the government facility, that is in the medical college, for COVID care. The staff is given compulsory leave for 14 days with home isolation. So this was our protocol. High-risk healthcare worker contacts, that is of this positive person, the high-risk contacts, that is less than 1 meter contact without mask for more than 15 minutes of the patient are tested even if they are asymptomatic. They were just tested at that point of time itself, and then they were sent for home quarantine for 7 days. If negative, they were allowed to join with strict masking and self-monitoring for the next 7 days. And they were specifically asked not to have food with anybody else, to have food alone. This prevents a spread to co-workers and patients, and the test would be repeated on the 8th day. High-risk patient contacts of the patient, that is, those who are caring for the patient, the healthcare workers, also patients nearby. They were shifted to isolation, all the patients, and closely monitored. If possible, patients are also discharged with advice to come after 14 days for readmission. Testing is repeated on the 8th day, and this prevented the spread to newly admitted patients. The low-risk contacts were not tested, but they were advised strict masking, taking refreshments alone, and close self-monitoring for symptoms for the next 7 days. So this was our protocol, and soon, I think within 1 month, everyone learned this protocol, all the healthcare workers, that what they have to do, they learned very quickly. I'll just show you how the clusters developed. This was a nurse. The first thing that happened there in September, actually I had a knee surgery and I joined. But the day before I joined, the medical superintendent called me up and said, Kavita, you have to come back soon and join because there is a cluster developing in the neurosurgery department. So that is a kind of attention that the medical superintendent gave to the slight increase in the number. We were so aware that we should not shut down. So this nurse in the theatre, she had a slight cold and cough, and she has spread it to all those who were doing the surgery nearby. But why? They were all wearing masks, isn't it? You will ask. No, she suddenly collapsed there. 1 or 2 days she came with her cold and cough, but then suddenly she had a syncopal attack and she collapsed. And these were the people who took her to the side room and resuscitated her. All of them became positive. Then this Dr. 1 had lunch with a project officer, and promptly they got it. Dr. 2 had a lunch with another Dr. 5, and that person also got it. So this is how the cluster spreads, and we had to stop it there. 1A was that, 1B. This nurse 1 had already spread it in the side rooms when she was changing her dress, talking and chatting with others. She had already spread it to 8 others here in the changing room also. So you can see how an epidemic, if you don't think about this, is the first one and we were not aware. So this is how it spread there also, in the side rooms of the operation theatre. 1C, 1 attender. Here you can see the unit helper, this person. He was asymptomatic. The red is symptomatic. Blue are all asymptomatic. This person was asymptomatic at this point of time. Next day he became symptomatic. Still he went to the other place, that is in the ICU. He had some friends in the ICU. Before you know, these things just happen. And it is only on the third day that you realize what happened. So what we did was, quickly we instituted a testing for everyone in that unit. Testing for everyone means it will come to 60 or 70 people, including the patients, everyone. All had to be tested. And this is how we got the cluster. Cluster 1, that is from 20th August, there was 1 positive. From that onwards, this is the day, 17 September, we called it augmented surveillance. That is, all were tested. And when we tested all, this blue is asymptomatic. So you can see all these asymptomatics were just sitting there, getting ready to spread it all over the hospital. And if this had happened, the whole hospital would have shut down. So here we caught all these people as positives, and all their high-risk contacts, all of them were put into quarantine. And because of that, we were able to stop it. By 29 September, the number had come down. But then there was another small cluster, again developed by the end of September. I think somebody escaped over here. But we were very quick at that point of time, and within 7 days we had stopped that cluster also. So we go into action as soon as 2 or 3 people become positive, get hold of all the high-risk contacts, test all of them, test the whole unit, and finally send all those people for. So temporarily this unit would stop functioning, but the rest of the hospital works. Otherwise, this would have spread to the whole hospital and everything would have stopped working. So these are the 4 clusters that developed during that period from in 2020. This is 11 September, 29 September, 19 days, 28 with 3 patients. And this was started by a patient's bystander. That is why the number of patients is more. One bystander was positive and he was walking up and down talking to everybody. So that is why this became patients in the ward. And this was in the ward while this was in the OT ICU. This was in the ward. Within 7 days we stopped it. Then this was in another unit, the cardiac side. It lasted for 16 days, 29 people became positive, of which only 2 patients. This was in the neurology side, that is from 9th to 24th November. Again, this was a patient. What I find is that when a patient becomes positive, there is more spread and quick spread occurs, because all the nurses will be taking care, and our neurology ICU and all are chronically on ventilators, and close care has to be given. So however much you're strict with your masking and all that, some kind of contact will happen. So this is the 4th. After this November thing, we didn't have any more clusters. The R0, that is the transmission rate, it ranged from 1.66 in the duty rooms to 6 in the ICU. ICU is a place where it is completely closed with AC also. So it's very dangerous if there is one patient in the ICU on ventilator with lot of secretions coming out. So it came up to 6 in the ICU, where the number increased when the index case was a patient. Review article I looked up in Infection 2021 said current consensus estimate for R0 for SARS-CoV-2 is between 2 and 3, which is almost like this, but higher estimates up to 14.8 have been reported from single outbreaks. And the heterogeneity of estimates of R0 can best be explained by the high inter-individual variance of the likelihood of transmission from. So there are so many factors which predict the likelihood of transmission from a single case. That is why we got such a range of R0s. So what was the lesson learnt during that time? Surveillance is an essential part of controlling the pandemic, since 52.6% of positives were asymptomatic. augmented surveillance is a strategy. So in the future, for any other diseases also, at the start itself, you can just test everybody. You don't wait for the symptoms to develop and then test. Augmented surveillance is a strategy that can detect asymptomatic or pre-symptomatic cases. They may go on to get symptomatic. Prompt isolation of all cases before they became symptomatic reduced the spread and halted the outbreaks. The percentage of positives contributed by the hospital to the state positives decreased remarkably after these control measures were implemented. And after December, we did not have any outbreak. Only one outbreak we had in the next October in the cardiac surgery, the children congenital heart surgery unit. But that was due to the Delta virus, not this one. Now, since talk is very specific about the healthcare associated infections, I went into, because we don't have any COVID cases, I went into literature to find out what happened. And here what I found was year 2020, these 3 years were totally different, isn't it? And the final thing is that in the year 2020, in Wuhan, it was all unexpected, so around 10% developed secondary bacterial infection. In Italy, they found that the lower respiratory tract infections in influenza, strep pneumonia is the main thing, but here it was mainly gram negatives. And also other viral, bacterial, all kinds of things came up with COVID. In USA also, almost similar picture. They did not study the viral infections and 3.7% of COVID patients. So in the COVID patients, there is nothing like extra hospital-acquired infections. Only thing is that if they remain in the hospital for a longer time, there is more chance of healthcare-associated infections. In the developing countries, of course, AIIMS is there, and compared rates of VAP, CLABSI, and they found that only CLABSI, that is central line associated bloodstream infection, significantly increased. ICMR in India collated the data, reported that 3.6%, so it's not a very high, of COVID-19 patients developed nosocomial infections. Studies from Iran showed that pneumonia, UTI, it was not there itself, and bloodstream infections increased probably because of all the IV drugs being given. Mortality rate definitely increased in all studies where healthcare associated infection was there. VAP, let us see what happened to VAP. Tertiary Care Center for Viral Infections found that compared to other viral pneumonias, probability to acquire VAP was more for COVID pneumonia. And rates range from 20 to 50% of patients there acquired the disease. Mid-2020, probability to acquire VAP was seen to be increased, and it was at this time that steroids started. So the cases of probable aspergillus had started to come in. And late 20 and early 2021, fungi started to appear in patients ventilated for a longer period, and Candida species followed by aspergillus and mucor. So that in India, finally this, I think it's the next one. Aspergillus was soon overtaken by mucormycosis in 2021, and mucor is mainly affected, did not affect the lung, mainly the nose and paranasal sinuses. It occurred after patient was discharged from the hospital. Since aspergillus came up in a big way, there was a protocol put in how to defining and managing COVID-19 associated pulmonary aspergillosis. They had a criteria to say whether this was really aspergillus pneumonia or contamination. So they put up this ISHAM, set up the consensus criteria for research and clinical guidance for aspergillus. And this is the CLABSI, see how it has increased. Here it is 0.56 earlier period in 2019. 2020 it has increased. Here also mainly in the ICU 0.68 became 1.16. This is the rate per 1,000. And the NHSN, that is US, there also they found that the standard infection ratio, there was a 28% increase in the national standard infection ratio from 0.68 to 0.87, and device utilization also increased nationally. And here also increase in CLAP C was the highest. So that is one information that is common everywhere.
Wind up as we are running short of time.
I don't know whether I have time for this. This is just a overview of what are the tests being done. I don't know whether it's needed. We had RT-PCR, gene expert, antigen. So these both are PCR. This is antigen and this is antibody. And RT-PCR takes the most time, 6 hours. This is a short kind of RT-PCR. These two are diagnostic. Antigen is diagnostic only in the early stage, and antibody, it's not known whether it is predicts immunity, but it may be a late stage diagnostic. Those who come with directly come with some complication of COVID, they can be diagnosed with this. But as soon as the vaccination came in, the need for doing an antibody test also disappeared because everyone had antibodies. The modes of testing were screening, surveillance, symptomatic, outbreak containment. Screening before admission and procedures, RT-PCR or rapid PCR. Surveillance, we used to test regularly every week, all employees or a specific group, RT-PCR. Symptomatic for diagnosis and isolation. Outbreak containment, we used augmented surveillance, as I said, of the particular unit or ward or ICU. So these were the different kinds of testing. And this is how I think we'll go. This is the last one, that CDC had given some guidelines on all these tests. Nucleic acid amplification test, highly sensitive, highly specific test. So these were the guidelines that we also followed. It was a big boon for me because we could interpret tests using these guidelines. What are the problems and issues? This I just want to say. The screening during a peak, if you simply screen people, during a peak of the epidemic, it will pick up asymptomatics, which is good also, but they will deny illness and they will phone you up and yell at you because they are healthy at that time and they will say that I am not positive. So during a peak, it will pick up asymptomatics, but during a trough, that is another problem, they will pick up false positivity will be there, and that can impact. If they are going for a surgery, a false positivity can stop their surgery. So in a trough period, it is better not to do this kind of screening of all patients. Repeated, and this is another thing that we faced. One RT-PCR is positive, again after 1 month, one more will be done, and this RT-PCR remains positive for up to 50 to 60 days. And this person again gets...
Wind up closes.
Yeah. Then the CT values. So many people asked us, this is the last slide. CT values, they asked us whether it is positive or negative. You cannot say it is infectiousness, you cannot say based on the CT values. Self-test is negative, but RT-PCR is positive. Self-test, generally it is an antigen test. So it could be due to sampling issues also. And waiting for RT-PCR negative test before joining work. So that is an administrative problem. That is why I wrote it there. It can increase the lost working days. Period of infectivity ranges from 7 to 10 days. So even if you are asked to join by 5 days, please wear your mask properly. So it was a challenging period, getting to know new tests and their interpretation. Clinical microbiology came to the forefront to tackle both clusters and healthcare associated infections. Sequencing of nucleic acid spread to all the medical colleges and even side labs. That was a major advance, and healthcare workers learned the appropriate use of PPE. Thank you.
Okay, thank you, madam. This is interesting but challenging and a lot of time also needed. I request the audience to have patience for a few more minutes. We now listen to clinicians and administrators and microbiologists. Now we just listen to the from nurses' perspective. I invite Mr. Jennings Joseph from Australia. Then we
Can you hear me?
Mr. Jennings?
Yes. Is it audible?
Increase the volume. Increase the volume.
Okay. First of all, I would like to extend my sincere gratitude and heartfelt congratulations to all organizers behind SASH 2002 and especially to the Dr. Jawahar, Pillai, who given me this wonderful opportunity. To begin this session, the first time I heard about the COVID-19 virus, mostly towards the end of January 2020. We all welcomed 2020 with much expectations, but COVID-19 pandemic disrupts our plans. But I didn't care much about it because I thought it was going to a similar situation like what we managed H1N1, Ebola and Nipah virus. But in March 11th, in 2020, WHO declared COVID-19 was a global pandemic, indicating a significant global spread of an infectious disease. So, I started my journey with COVID care on the 8th of February 2020 in Medical College Hospital, Trivandrum, Kerala, with 7 patients in an isolation ward that were suspected cases. And it was very easy to tackle their situations as the number of patients under the care and treatment were very less. As the days progressed, the number of infected cases increased and healthcare workers also being infected. In these instances, I can quote one of my experience with the Kasaragod COVID mission, which was the first in our country and second in the world. After the Cuban medical team mobilized to Italy to care the affected people, our team comprised of nearly 25 members, doctors, nurses, and nursing assistants from Medical College Hospital, Trivandrum, mobilized to the Kasaragod district, one of the northern part of Kerala, on the 5th of April 2020. But I can proudly say that with the help of all people, all the teamwork, coordination, commitment, support from top to low levels, and moreover practicing the infection control things, made Kasaragod COVID mission a successful thing. And it was the first district in India to become the zero infectivity rate at that time. But suddenly, what happened to the scenario? Why our infectivity rate and mortality rate got rocketed suddenly? Initially, we had a fear and anxiety towards how to manage the situation. So we all followed the protocols of the infection control. We all people, especially the public, also followed all the principles of the infection control, especially like the hand hygiene practices, mask and social distancing. But day by day, we got a notion that this pandemic will continue like this and why we have to follow all those things. I think the question why may lead to such a devastating situation all over the country. And another important reasons why these infection control practices are not much followed, or why this ambiguity or the infectivity rate among healthcare workers are occurred as follows. The most important lacunae, I found out that there is the inadequate manpower resources. Sometimes in a very busy ward or very busy ICU, only 2 nurses or 2 nursing assistants or with 1 cleaning staff for each shift have to work to look after these infected persons. Another important thing is the physical exhaustion, especially during the night shift. Sometimes there will be no breaks Sometimes we have to continue 12-hour duty shift. Another thing is that the physical problems, especially faced by the females, especially during the menstruation period, mental stress, social isolation, sometimes the insufficient or the low quality of supplies, and improper planning and coordination. So, in this situation, we have to remember the most important principles of administration like post-call. The planning should be very important, organization should be very important, staffing, directing, coordination, reporting, and budgeting. Towards my nurse's perspective, I know that it is very difficult to manage a pandemic with very less resources in the initial scenarios. But we have to follow some protocols, especially in the initial situation. Most of the governments in India itself, we followed the main protocol, that is the SMS. Very important thing. The usage of soap and sanitizer, usage of the proper mask, and social distancing. And the second one is the standard precautions that we are learning from the very beginning stages of our all medical professionals' education. Especially the very important thing is the hand hygiene, use of the personal protective equipments. Another important thing I can quote, that is the N95 fit test. We all use the N95 throughout this COVID-19 pandemic. But I think I never seen in our hospitals the fit testing of N95. We all know that we can our hospitals, but the main thing we have to focus is the fit testing of the N95 mask. And next one is the respiratory hygiene. Whenever we are coughing, we have to follow some coughing etiquettes and safe handling of the supplies. Third one is the environmental infection control. We have to clean, intermittent as well as the terminal disinfection of the ward and the ICU. And the fourth important thing is the role of link nurses. I think all over in India, in very big hospitals, the role of link nurses should be very appreciable, because link nurses can supplement the activities of the infection control nurse. So this link nurse can act as a catalyst in a particular unit or a particular ICU, which they can educate all the healthcare workers in that particular unit. And the last one is the safe documentation. I know that most of the hospitals following still the paper recording, but we have to follow the electronic medical recording. That will be very beneficial during this pandemic situations. So my high-tone recommendation for this infection control practices is the N95 fit testing for all healthcare workers annually and providing certification and use of appropriate N95s. And instituting clinical coaches for the effectiveness, to assess the effectiveness of using this personal protective equipment as well as the clean hand hygiene. Third one is the clinical surveillance of the infection prevention control activities, electronic medical recording, involving all the workers, healthcare workers, in the planning phase itself. Not only the higher level managers, we can also include all the low level managers and the middle level managers in the planning phases. And conducting mock drills every 6 months and using our skill labs, especially when we are using this full PPE. The main thing is that we cannot do the procedures as like in the normal scenarios. So use of the skill labs and training. So in conclude, the main successful mantra for the infection control activities is the proper planning and coordination of all the departments following the SMS protocol, not only in the hospitals, in everywhere, ensuring the staff safety as well as the patient safety. So safety of staff is very important. Proper communication of all the policies of the hospital, ensuring training programs, self-learning, online learning, training, use of personal protective equipments properly, especially the hand hygiene practices. And finally, every health worker should be very assertive, a good listener, and honest. So, this is all a nutshell regarding in the nursing perspective of infection control practices in the COVID-19 scenario. Thank you once again for giving me this wonderful opportunity. Thank you.
Thank you, Mr. Joseph, for raising relevant issues related to nursing care of COVID. We have had 4